My name is Roger Lewis. It's a pleasure to be here. I'm going to talk for the next 25 minutes about what an IRB does and why, and try to give you some tips for working effectively with your IRB. You haven't seen me much. I've been sequestered over in the so-called advanced track. It's nice to be in a larger room. I have some financial disclosures. None of them have anything to do specifically with human subject protection. And most of what I'm going to tell you is drawn from the federal regulations, so I have very little opportunity to hold. So the historical perspective is important to understand why it is that we have human subjects regulations. People usually start in discussing human subject protection by pointing to historical abuses of human subjects, which frankly have gone back hundreds and hundreds of years. But certainly during World War II, there was particularly noteworthy examples of abuses of human subjects for various purposes, some of which were primarily abusive or military in motivation, but some of which were actually motivated by some attempt at scientific discovery. But after World War II, there were a number of things that occurred that helped to clarify thinking internationally regarding how we protect human subjects. The Nuremberg Code specifically is one of the first places where the concept of freely given prospective informed consent is defined as a requirement. And the Declaration of Helsinki establishes the concept of there being a need for independent review and approval of a research project involving human subjects as important protections. Nonetheless, after both of these documents were developed, there continued to be a number of very noteworthy abuses of human subjects, which the CTMC experiment is the most commonly cited, but there were a number of them. Oh, I should also mention in World War II, we generally think of Germany as sort of the example of human subjects abuse, but in fact there were quite a few countries that, if you look into the history, have really thought-provoking patterns as well. In the syphilis experiment, human subjects were enrolled who had syphilis, and then even after effective treatment was developed for the disease, they were neither informed of that development nor offered that treatment, and therefore suffered preventable morbidity and mortality because of their participation in the study. After that, the Belmont Report was issued. The Belmont Report really establishes a number of foundational ethical principles on which the subsequent human subjects protection regulations are based. The first is the respect for persons as individuals. This is a core value that basically says that we respect individuals. And part of that is that they have, when they are able or competent, the ability to individually prospectively decide whether or not to participate in a research study and to withdraw at any time without penalty. The second is beneficence, which you may think of as the do no harm, but this really goes beyond that. It refers to the appropriate balance between the potential benefit to the individual subject or to the class of subjects that are being enrolled in the study and the risks that they entail. And the last, which I think is of the three probably the less well understood by many people, is this concept of justice. And that is the idea that the population that bears the burden of participating in human subjects research and bears the risk must also be the population that has the potential to benefit. So it's not okay to enroll a bunch of patients in a research study in one, for example, socioeconomic or demographic or racial class in order to develop a drug or a treatment that will then in reality only be made available to a group from which the subject will not draw. And it's a very important concept. The goal here in general is to kill as few people as possible and hurt as few people. As we move forward, I try to put this slide in almost every talk I give just to point out that the goal here is number one, to hurt as few people as possible, and number two, it's actually good to be in the placebo group to get the benefit of careful attention of the investigators and none of the risks. So I'm a fan of the placebo. Okay. What I'm going to try in the remaining period is to convince you that you should actually read 45 CFR 46. Okay? It is not thick. It's right here. It's freely available. The government website rarely goes down. And it's actually well written. And if you understand these regulations, when you've actually read them and you know what the terms mean, two things will happen. Number one, you will understand why the IRB does what it does and why it responds to various things the way it does. And you will be able to respond using language that is precise in providing your argument for why your research is ethically and appropriate and has an appropriate risk-benefit ratio. If you don't know what the terms mean, you will likely write things that will make you appear uninformed or at worst arrogant or irresponsible. So I'm going to just throw out one. So what is minimal risk? How many people have heard the term minimal risk in the setting of human subjects protection? Nobody. They're short words. Nobody?
Just not more than that accounts that are going to be
Very good. That's 2/3 of it. Anything else? No. Okay. So that's the key point. Minimal risk is not just a late phrase. It means specifically, that's in 46.102, the risks associated with the activities of everyday living or those encountered in routine physical examinations or in the or use of psychological tests. Notice it doesn't say a physical test, which will often raise the question of whether just routine blood draws would fall under minimal risk, and that's commonly debated by age group. But the point is, you can't just say our study of cardiopulmonary resuscitation in the setting of acute thoracic aortic injury entails no more than minimal risk because it's so bad we're not adding much risk. That is an incorrect use of the term. So it's important to actually know what the terms mean. So 46.101 actually defines the activities to which the human subjects protection regulations occur. So the first thing in your IRB application or your institutional procedure is going to be aimed at trying to get you to give them enough information so they know whether the regulations apply. As a general rule, the regulations apply to research that is supported by federal agencies. However, virtually all of you will be at institutions that have something called a federal-wide assurance in which your institution has voluntarily agreed that all of the research, whether federally supported or not, will be subject to the same review and approval procedures. So for all intents and purposes, all of the research that we do falls under these regulations if it involves human subjects. There are some research categories that are of such minimal risk that they can be defined as exempt. It's not expedited, that's a different term. Exempt from the regulations, which means the regulations don't apply. Most institutions that you and I work at have agreed that the individual investigator should not be the one to make that determination because we might want to make it seem like our stuff is exempt. And therefore the IRB or the Office of Human Subjects Protection or equivalent at your institution reserves the right to make that determination for you so you can't game the system. 46.102 gives definitions of several things. I already brought up minimal risk. It defines what is research. Research is basically any activity that involves human subjects where the intent is to create generalizable knowledge. The place where I see people get confused over this is usually a QI project. So if when you're doing your QI project, you intend to generate information that will be only used within your own institution to improve processes, that is probably not research. If you intend to reserve the right to publish it, if it's a really good project, that is research. It is not okay to do something with the idea I'm going to publish it, but sort of hide that at the end and say, now I'm thinking of publishing it and try to go back and get IRB approval for it. That doesn't make your IRB office upset, and they will remember you. It defines a human subject. A human subject is a person in whom you either directly interact with in order to obtain data that's used for research, or you obtain essentially the equivalent of protected health information or private information that would normally be available even if you don't directly interact with the individual to get that information. That's what a human subject is. When you're doing studies of interventions at the physician level or at the resident level, I guess residents are physicians, resident or that physician is a human subject, because physicians are actually counted as humans as well. So please remember, when you're doing something that's a organizational change research project, everybody you interact with and everybody who is impacted by that may be considered a human subject. 46103 talks about why we have institutional review boards. Institutional review boards are really a fascinating social solution to a history of problems in this area. In that the idea was that we would have a multidisciplinary group that involved both experts in the area and lay representatives, but drawn from the community in which the research was likely to be conducted to review. So it's essentially it's not exactly peer review, it's sort of peer review plus, because it has both peers and non-medical specialists by regulation that give a lay perspective in principle to the research that is being conducted. It talks about the number of members. There's a minimum of 5, and this concept that they should have varying backgrounds. That is why most IRB applications require that you write a summary in lay language, if so those lay members that are required by law can actually understand what you're doing. I cannot tell you how difficult it is to get a paragraph that makes sense to a lay person out of some people. Okay? And if you don't do that, you are showing a lack of respect for those lay representatives, and it actually defeats the intent of the regulation, which is the research should make sense to an expert and should make sense to a non-expert who in some sense represents the population that may be involved in the research. Section 46109 talks about what kind of research or what kinds of things the IRB has to evaluate. They have to review your research proposal before you're allowed to enroll your first human subject. I think people are aware of that. They are, by regulation, have to review the consent form and the procedures that you're going to use to administer consent. So one of the misconceptions sometimes of people who are not very experienced or well trained in this area is that consent is a form. If I can get a signature on a form, I've got consent. Consent is a process through which the human subject is given the prospective human subject is given the opportunity to understand the research, its benefits, its risks, the burden of participating, have their questions answered, and then give a non-coerced, free consent to either participate or decide to decline participation in that research. The form is a form of documentation of that communication process. I'll just tell you an anecdote. I was sitting in a hospital room, and my spouse was undergoing an amniocentesis, and they were doing the usual stuff, and suddenly we got one extra form thrown at us. My spouse happens to be a professor of medicine at a research university, and it says, "Can you just sign this extra form?" So I look, and at the very top of it, it says, "Human subjects consent." Okay? And the process of human subjects consent for us was turn it over, flip, show us the signature part on page 3. Okay? You don't know me. Some of you know me well. Trust me, I was upset. You can probably picture that if you know me. Okay. So it's a process. It is not a form piece of paper. The third thing that the IRB must do by law is continuing review. No less than once a year, they must review some information regarding the ongoing conduct of the study to see how it's going in terms of subject enrollment, and essentially to make sure you're not doing anything that is beyond what they expected you to do, or what your experience with the protocol has not demonstrated or suggested there are risks above and beyond what was originally provided in the documents that they reviewed. There are a set of categories of research for which the IRB can use an expedited process. So exempt is the word for it doesn't actually, the regulations don't actually apply. Expedited means the regulations apply, but the full committee does not have to review your protocol, and therefore you can get a more rapid review. Interestingly enough, the categories of expedited type research are not contained within the regulations. The regulations say we will maintain a list, and then you have to go to this website to actually see what the list is. This, I thought, was a nice sort of fluid way of not having to rewrite law every time someone thought of something different or wanted to update these. But these are the things like minimal risk research, research using surveys, research in which the only risk of participation is likely to be the actual loss of confidentiality if your identity is released, but the actual procedures entail no risk, non-invasive sensors. There's a whole educational test. Anyway, there's a whole list of these categories. If you ever are submitting a proposal and you believe that your research falls into an expedited category, please take the time to read the exact definition of that expedited category and address each of the requirements. So if you think you're not doing something invasive, try to look at the one on use of non-invasive sensors and that sort of thing, so you're using the right term. Minimal risk research, remember the definition of minimal risk associated with everyday activities or routine physical examinations or psychological tests. And lastly, if you have a study that has previously been approved, the continuing review or the improvement of minor changes in that protocol can be approved through an expedited process. Just so you know, what the IRB actually does is even if the vice chair of the IRB approves something in an expedited review, they then make the full list of those protocols available to the whole committee, so if someone on the committee may later ask a question about it. So if you get something back from the IRB afterwards, that's because they were complying with the requirement that the full committee have an opportunity to review the list of things that were approved by the expedited route. Is that convoluted enough? So there are essentially no pictures on the web of IRB, so this is a random committee meeting. They're all secret. Okay. It says, what do they actually talk about? They talk about exactly what is in 46111, and in general, they talk about it in this order. So the reason your IRB application asks you these weird questions in a particular order with specific terms is because this is what they're told they have to consider. Okay? So they first will ask you if the risks are minimized. And so you're going to have to say something about how you're going to minimize the risks. They're going to ask you if the risks are reasonable relative to the expected benefits and the value of the knowledge that may be gained from your research. This may seem similar to the first one. These are two separate parts of the regulation. That's why there's two questions. They're going to ask you how you select subjects and whether it's equitable. That is related to the principle of justice. So you're not selecting only patients who in some way are easily coerced or feel as if they are not in a position where they can decline. They're going to ask you about the informed consent process. Who's going to give informed consent? Is it the subject? What will be the cognitive ability of the subject or their ability to understand at the time? Are you going to seek consent from legally authorized representatives? And just a word about this, be very clear in your mind that what is an appropriate legally authorized representative for research consent is different than what is an appropriate person to give consent for routine clinical care. The underlying principle here is that when you get consent for routine clinical care, you're getting a consent for an LP because you're the patient's doctor and you think that this test has benefits that outweigh the risks. The assumption is that your only interest is in the welfare of that patient. Okay? So the requirements of who signs the consent for that LP is determined by your hospital policies and procedures is frankly relatively lax. If you're doing that LP for research purposes, the exact same procedure, you have to know who's allowed to give consent if the patient can't give their own consent. Who's a legally authorized representative for research. It's different because at this point you're not doing it for the benefit of the patient, you're doing it for the benefit of your research protocol, your career, your ability to apply for funding. You have an inherent conflict of interest. Okay, so that's why it's different. And sometimes physicians early in their research career fail to understand this distinction, and you do so at your own peril. Different states differ in their regulations regarding who's allowed to be a legally authorized representative. Usually it has to do with things like how distant in the family it can be. Does an adult child count, those sorts of things. And you really need to make sure if you're doing a research project in which the human subject, the research participant, is unlikely to be in a position where they're cognitively able to provide free informed consent, you really need to be very clear with your IRB who else you might or might not ask to make sure they're on board with that. I've seen a number of people have difficulties in that area, put it that way. Especially in neurology research, my area of emergency research, be aware that people with neurological conditions or emergency conditions, even if they're conditions that are not generally associated with cognitive impairment, have a lot of trouble understanding things in acute care conditions. If you take someone who you just told is having an acute myocardial infarction, and you try to give them any cognitive test right after you tell them that, they are cognitively impaired. And so we want to try to adjust our consent procedures and who we ask and how we document to take that into account. And I think there's been a lot of movement in the last 10 years, maybe 15 years, from what we used to do, which was give someone who's panicked, if you're having a stroke, oh, by the way, you can read this 15-page document, to things that are more sensitive to the position in which the patient finds themselves, and sometimes follow initial abbreviated consent procedures with more extensive consents to continue in the research, for example. There is an emergency exception from informed consent for investigation of therapies for acute, unexpected life-threatening conditions for which there are no accepted effective therapies. This is best codified not in the HHS regulations, but in the FDA regulations, which is 21 CFR 50.24. It's very short, okay? And it's really well written and thought out. The person who wrote that at the FDA, who was one of the primary writers for it, has unfortunately passed away, but gave a tremendous amount of thought to trying to write a regulation that preserved the ability to investigate treatments for life-threatening conditions and preserve human subjects' protections to the extent possible. Documentation of informed consent is separate from the process. There's actually two different ways to document it, which a lot of people don't know. One is the traditional informed consent document that can be read to the patient, can be provided with them to take home, and at some point they sign the document. They're signing the full long form. There's actually an alternative accepted practice, which is an oral presentation with a witness of the information, and what they sign and take home is an abbreviated, simplified version of the consent form. I only bring this up, and I don't think I've ever seen this done, because what it allows you to do is to send them home with something they can actually read, and to me that seems like something that might be a good idea, but sending them home with a longer document. The IRB has to consider how they're going to monitor, how you're going to monitor the study data, and how they're going to review that. How are you going to keep track of the burden of adverse events, serious adverse events, patients lost to follow, other things that might go wrong in the research, especially those things that would indicate an increased risk to subjects. They're going to worry about how you're going to maintain privacy and confidentiality. There are a number of places in the regulations where it explicitly states that if the only risk to the patient is the loss of confidentiality, you may actually not have to have a written consent form, because it's that consent form in whose existence constitutes the major risk to the patient. And then they're also going to worry about how you protect vulnerable populations, whether they're children, cognitively impaired, acutely ill, prisoners, pregnant women, etc. And especially a lack of coercion. And the thing I want to talk about for a second here is the use of financial incentives in research. So this is an area that I think is really, in which there's a lot of interinstitutional variability. So many of the research protocols that we ask patients to participate in involve multiple visits, lost time off work, or other disruption of their life, and they involve bus trips or parties, etc. And it is commonly felt to be appropriate to compensate patients for, in a reasonable way, for their time and trouble. What is not considered okay is to give people money to pay them for use of their body for your academic career. And the line between those are very difficult to define. And frankly, the dollar amount that would cross that line probably depends on the patient's own financial circumstances. So institutions often vary in this. If you're doing multi-center trials, I think it's a particularly difficult area to try to come up with something that's reasonable. And so this is an area where it's very useful to talk to your IRB head ahead of time to see what the accepted practice is in your community before you try to fix an amount. There are also other kinds of coercion. I can't really give you this treatment here because the only doctor who knows how to do that surgery is this really wonderful doctor. That really wonderful doctor gives you a much better chance of living, but he only enrolls patients who are in this other research program. Or, you know, all kinds of forms of coercion that are not financial. 46.116 gives the general requirements for informed consent. If you look at this section of the regulation and the informed consent template for your institution, you will see that the regulation is the outline for your informed consent form. It says, this is research, it's voluntary, this is the purpose, what the risks are, what the benefits may not occur, what to do if you're injured, whether or not if you're injured there will be compensation for your injuries or payment for the cost of treatment of your injuries, who would fall if there's a problem. All those sections that are in your consent form are in this section of the regulation. Why is this important? It tells you why you cannot just say this doesn't apply and cut it out, because that violates the regulation. It was long ago pointed out to me by an FDA lawyer that I shouldn't use the term regulation, I should call it law, because that's what it is. So don't try to get around it. 46.117 talks about how you document informed consent, and that's where it talks about signing a long document versus an oral presentation and signing a more abbreviated form. There is a separate section for children, and whether or not you think they're little adults, it separates out the categories in which it's okay, or categories of risk and benefit in which it's okay to provide research in children. And the place that I would specifically point you to is that there's a category for research that involves more than minimal risk, does not benefit the individual child, but has the prospect to benefit the population of children affected by the disease. And that's something that's sort of worth actually reading the regulation, because that's much research falls into that category, and it is one in which there's quite a bit of variability in IRBs how they interpret it. Okay. I'll follow up by talking about IRB structure a little bit. There's been a movement towards centralized IRBs. This word is just the one that came up first on my Google search. I have no financial interest in them. The use of central IRBs can greatly streamline the review of proposals or protocols that are multi-institutional, because once the IRB has seen the first version, they actually know what the interventions are in the population and stuff from site to site, which shortens their review time. It also improves the consistency of review. If they made this site explain this risk a little better, they're likely to require that for all sites. The downside, in my mind, of centralized IRBs has to do with the lack of knowledge of institutional considerations. They may not know that in my institution, that unless the research associate is a native Spanish speaker, it just ain't going to work. Okay? And they also are less in a position to do the continual review and look at the individual data on an experience and adverse event experience coming in from all the sites. But it's a good way for multi-center trials to improve the consistency of the review process off the top. Many for-profit sponsors and some government agencies are now requiring centralized IRBs because it decreases the time to get the trial up and running, and that the startup time is a huge cost in both settings. Okay. And I just said all that. Oh, they vary tremendously in quality. Your institution probably has identified one or a few centralized IRBs that they're comfortable with. And if you're at all involved in human subject protection, I would urge you to do that. Okay. So I realize the regulations are not the most fun reading, but it really is a good investment in your time to read them so you understand the language that is in your IRB application and the way the IRB thinks about these things. It's not just them being crazy. And if you do that, it's a way of actually showing respect for the IRB and the human subject protection process. That credibility. And if you come into the discussion showing that you're aware of the regulations and the intent of the regulations, I think it's much more likely that you can come to an appropriate, reasonable agreement with the IRB regarding consent procedures, populations, compensation for time of trouble, and that sort of thing. And please follow your institutional policies and procedures so you keep yourself out of trouble. Thank you very much.
Questions?
Yep.
You mentioned the part about the oral presentation in the short form. Can that be done with someone who's a non-English speaker, or do you have to have your full IRB translated into that language? You do the oral presentation with a non-English speaker.
So if you are, it's a great question. If a language is represented with a reasonable frequency in your patient population, most IRBs will require you have a professionally translated version of the form, both the long form and the short form, for that population. So in my institution, I would have to have one that's in Spanish. If you have a language that is quite rare, someone comes into my institution who speaks Swahili, I am often able, and I have permission ahead of time, to use a professional medical translation service to do the translation for those rare patients. So usually the IRB, depending on your profile of your study, will come up with something reasonable. But if your population has a high fraction of a foreign language, you will be expected to get a professional certified translation of that. Okay. There's one question over here.
Yes, hi. Could you comment a bit about compensation for subjects when they're normal human volunteers participating in phase 1 subjects in phase 1 mills, where people may stay as an inpatient for weeks and weeks at home?
Well, I think the term phase 1 mills sounds a little pejorative. So starting with that bias in the question. It is a very strange, to me it's a very strange part of the human interaction between research and subject, where you ask someone to, sit in an inpatient unit essentially for 3 weeks while we give them something that's never been given to humans before to see what happens. It's an incredibly important part of research. To me, the compensation needs to be something that strikes the full IRB as fair and not coercive. I have been aware of cases in which the people who choose to participate tend to be people who don't have alternative housing available to them at all in the winter in the Northeast. And whether or not that's coercive, I think it's really a tricky issue. So in doing the ongoing review of phase 1 research, if I was on an IRB, I would be looking at the demographics of the population. And if you are doing all your phase 1 work on homeless people to generate a treatment for immunosuppression of people after heart transplant, that would violate the principle of justice. And that should be a concern. And there was one more question, and I'm going to ask you.